माइक सब कुछ बंद है। अब हम यूट्यूब पे चलेंगे। अब आपने मेरे फोन से यूट्यूब देखना है और अपने फोन से जूम देखना है। देखिएगा मतलब कि ठीक काम कर रहा है घर में बैठ के। हाँ कश्मीर में बैठते लेकिन बैठते घर में लेकिन ठीक है। वैसे बैठे वैसे बात नहीं है। Now you're audible. All right, and your video's here, and you will go to this and it will start. Right, make sure. मेरे पास एक आइडिया है छोटा सा. लेट मी ट्राई. नो बट वी आर ऑडिबल. जब सही करेंगे। और इसका साउंड ऑफ है, मैं लगता है देख कर पा ऑफ कर दूँ। हाँ ठीक है, लेकिन आपकी कोई वीडियो है साउंड वाली, वो मैं खुद ही सुन एक्सप्लेन कर दूंगा, एक्सप्लेन को। प्रेजेंटर भी नहीं, इंटरनेट ऑन ऐसे बता देंगे आप। उनका उनका कुछ नजर आ रहा है ना, वो अच्छा नहीं लगा। बड़े ही बड़े वही है। लाया होगा। प्राइवेट कॉलेज में स्टूडेंट प्राइवेट मेडिकल कॉलेज में आपकी बड़ी मेहरबानी है। जी सर। आपको दिखाते हैं बहुत बड़ा हो गया। पहले हमारे पास कम होते थे बेड, 8 बेड होते थे, उसी में 4 रेजिडेंट चढ़ जाते थे। ठीक है सर, वो पहले जरा ज्यादा मरीजों की तादाद में बढ़ गई। पार्किंग बाहर बंदा खड़ा हुआ है पार्किंग के लिए आपके। ठीक है, नहीं नहीं कोई मसला नहीं, कोई मसला नहीं। मैंने कहा वो पार्किंग के लिए बंदा खड़ा हुआ है, आपको मुश्किल नहीं होगी। ओके। 8 बेड होते थे, मैंने किसी को यार हमारे पास 8 बेड है, देख जाओ। वो पहले वो बड़ा ऑर्गेनाइज करता था, पॉइंट हो गए 8 के 8 टीम में, टीम में ओवर पॉपुलेशन है वो हर चीज ऐसे अगर साइड दिया ओवर पॉपुलेशन बहुत ज्यादा दिक्कत है उनके साथ साथ काफी दिक्कत है जगह में कपड़ा उन्होंने पहले ऑफर किया है या एक का बन रहा है किराए पे इतना क्लैश हुआ तो पहले इसका सही था तो सही था थोड़ी लड़ाई हो गई इस तरह का तीन साल रहा पूछ रहे हैं ऑनलाइन भी आ रहे हैं ऑनलाइन है क्या वो ये हमारा यूट्यूब से भी जा रहा होता हाँ जी वो ये जब से ये बड़ा हमारा सिस्टम डिस्टर्ब हुआ जब से नेट फेमस नहीं हो गई ये मतलब कोई लाइव जा रहा है बड़ा मुश्किल एक पता है आवाज नहीं आ रही भाई हो ही नहीं कह रहा तो आवाज नहीं आ रही हाँ जी हाँ जी हाँ जी वो मैंने दे दी मानो चल रही है दो प्रोफेशनल मॉडल तैमूर है और शानदार चार पाँच नहीं 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 दस मिनटों में पाँच ठीक है। बस अब मैं शेयरिंग जी सर बस हो गई। Sharing is closed as the window. No, that's right. First, then हमें करना है स्लाइड शो। अब हमारा हो जाएगा स्लाइड शो। हम यहाँ से जाएंगे, ठीक है? एक सेकंड, हम यहाँ से जाएंगे जूम में। एक्चुअली ना, हम्म, हमने इधर स्लाइड शो। ये अब वो हो गया थोड़ा, वो मतलब बता नहीं रहा है। छोड़ा यहाँ जो है ना आपका आगे मेरे खबर नहीं। जब मैं इसको बंद कर रहा हूँ ना रिंग में प्रेजेंटर में ऊपर, तो ये शॉर्ट हो जाता है। और वैसे लैपटॉप आप वो करें प्रेजेंटर, इसको करें यहाँ से करते हैं, यहाँ से भाई अब हो गया। अब आ रहा है इधर, चलो बस ठीक है। हो गया ना? ठीक। नहीं बस चेक कर ले। चेक 1 2 3।
Hello, hello, hello. Sir, may I begin? $61,076. In That's 1.7 crore rupees. Can anyone understand the astronomical amount of money that is? And can anyone guess what that amount is? Is it the average salary of a rhinoplastic surgeon? No. That's the cost of litigation per case levied on cosmetic surgeons, according to a study published in a Canadian plastic surgery journal in 2021. I apologize for that.
अच्छा, अब वो आपने कैसे नीचे से किया था देवी? वो क्या था? इधर से इस पे से, अगर वो आपका नहीं होंगे आप। आगे आगे जा shut down. Right now.
Okay, sorry about that. Let's begin again. Assalamu alaikum, everyone. My name is Dr. Shahzain Hussain, and it's my honor to be presenting today. $61,076. In Pakistani rupees, that's 1.7 crore. That is an astronomical amount of money. Can anyone guess what this amount is? Is it the average salary of a rhinoplastic surgeon? No. This is the per case litigation cost levied on cosmetic clinic. And all for what? This could have easily been avoided if we had the right techniques, the right counseling, and the right patient selection. But let's look at the other side of the coin. What if we have the right techniques? What if we have the right counseling? And what if we are experts in this procedure? This is obviously one of the most attractive fields, high earning profession. And as doctors, we don't just care about the money. We care about our patient. Miss Aisha is a young female patient, and she will be the case study presented in today's presentation. Keep this picture in the back of your mind. We'll be coming back to her at the end. Augmentation rhinoplasty. So what is augmentation rhinoplasty? It's a nasal surgical procedure which improves the shape, the structure, and the function by adding things into the nose. So that could be sutures, it could be grafts, it could be anything like that. These are some terminologies that we should be aware of, especially the glabella, the nasion, and the menton. These are appropriate landmarks which we will be discussing further in this presentation. Three major areas which we have to take care of during any nasal surgery, especially rhinoplasty, is the keystone area, the scroll area, and the soft triangle. So the keystone area is this area right here. It is the point of junction of the nasal bones and the upper lateral cartilages, and is a major supporting point of the nose. If we disrupt this, it will lead to collapse of the nasal structures. Number two, the scroll area. Now, as we can see here, it's the junction between the upper and the lower lateral cartilages. This is the area of the internal nasal valve, and we all know the importance of that in breathing. In addition, an intercartilaginous incision in closed techniques can be used to access the dorsum through this area. Number three, the soft triangle. The soft triangle is this region right here, between the anterior septal angle and the dome. This region is important in planning incisions and being careful during dissection, because if we dissect too much here, we will have excessive scarring. Here are two aesthetically pleasing noses. Yes? Aesthetically pleasing? What about that? I know it seems funny, but the objective today is to find the right nose for the right person. And that's the goal of rhinoplasty. We already selected the right patient as discussed by our co-chief resident, Dr. Ali Shayan, and today we'll be discussing the further things needed for an excellent rhinoplasty. That's the right approach, the right materials, and the right techniques. The right approach. So, as we all know, the two approaches that we use for this procedure are a closed approach and an open approach. And the easiest way to think about this is if there is excessive nasal deformity, we have to do an open approach. And if the nasal deformities are of a limited nature, we can go for the closed approach. But do remember, that does not mean a closed approach does not have its utility. So this is demonstrating the closed approach, and this is known as the delivery method. So we're delivering the lower lateral cartilages through the nasal openings. We will make an intercartilaginous incision, extend that medially, dissect out the cartilage, and then disrupt the interdomal ligament, and we will have this beautiful lower crust visible here. Let's see its utility. So we can place grafts. This is a columella strut. You can apply sutures, and we can even access the dorsum through intercartilaginous. Here's a brief video demonstrating an open rhinoplasty approach, which is very, very popular in arthrotops. We carefully make a columellar incision. This is a step-back division. We also have inverted V. We have multiple incisions, but the ultimate goal is to gain access. This is then onto the margins, marginal incision, and ultimately we'll have a beautiful view right here. We will then go for a septoplasty and we will mend any deviated nasal septum. So now we know the right approach. Excessive deviation, excessive problems, go for an open approach. And if it's more limited nature, let's go for closed. Let's talk about the right materials. And as ENT surgeons, we go for 2 to 3 major materials. That's the concho cartilage. And here we have a video describing the harvest. We'll inject local anesthesia. And this is the posterior approach for a concho cartilage harvest. We'll slowly dissect the soft tissue, exposing the concho cartilage beneath. And ultimately, we will have a beautiful piece of cartilage. Now, with the concho cartilage, there are a few caveats that I would like to highlight. First of all, is its shape. It's concave, and therefore its utility in most plastic procedures is quite limited. In addition, it is relatively brittle compared to, let's say, the septum or costal cartilage. Here we can see the surgeon beautifully dissecting out this concho cave, and he will then present us with a nice piece of cartilage. Compare this to a costal cartilage, which we'll be seeing very soon. We can use up to 3.5 centimeters of this without affecting the shape of the ear. So don't worry about the shape of the ear. We can harvest this regardless. Here's the incision, and here we can see an end block of a nice piece of cartilage. Talking about the costal cartilage, and this is very, very nice for dorsal augmentations. And in dorsal augmentation, we favor the 7th costal cartilage. Here we can see the surgeon accessing the rib. We will then take off the pericondium, slice it off the bottom, and then we will have a nice, straight, strong piece of cartilage. Here we can see the surgeon coaxing it out, and then you will deliver this. Obviously, we have donor site mobilities with these modalities, but their results are exceptional. We can also have other things. We have dermal fat, we have the temporalis fascia, and here we have a dermal graft. Always remember, the more rigid something is, the greater support it provides. So a cartilage will provide greater support than, let's say, fat. But fat and temporalis fascia has a nice contouring effect, meaning it has smooth transition. So if we want to camouflage minor defects, maybe we can go for a fat or a temporalis fascia graft on the nasal dorsum. Here is a silicone I and L implant. We don't usually use these a lot, but in patients, let's say, who have multiple revision rhinoplasties and we're in a pinch, these can have a utility. However, we always have the problem of graft extrusion and the foreign body reaction. So now we have the right materials. What's that? The right techniques. And when we deal with rhinoplasty, we always think about it in thirds: the upper third, the middle third, and the lower third. And the upper third comprises the nasal bones, the middle third, the upper lateral cartilages, and this is the nasal valve region, and the lower third is the nasal pit. I'll be addressing both of these together. And the way we'll go by this is, first we'll have a look at some ideals. What are we trying to achieve? Then we'll look at some deficiencies within the noses, and then we'll see the techniques that can be applied to resolve those deficiencies. These are our ideals. And this was beautifully presented by Dr. Alishan in the previous presentation, but just a brief recap. So the nose makes about 1/3 of this longitudinal distance and 1/5 across. We have these angles that we have to take care of. In addition, the nasal length should be, from the nose to the tip, should be about 1.6 times the distance between the tip and the deformities. So this young lady has a flat dorsum. This is a supratip depression right here, and the deep radix seen on the dorsum. A saddle nose, we're obviously very aware of this deformity. And interrupted dorsal aesthetic lines. So these lateral limits, these are known as the dorsal aesthetic lines. And we can see that these are not smooth in this patient. And this is a short nose. So if we look at the rule of thirds, this is far, far less than the ideal length. And this is a valvular collapse. See the prominence of the alar creases here. So this patient will have a dynamic effect, meaning that when he sniffs in, this will go further inside. So what are the corrections? This is highlighting the various different modalities we can use to correct these dorsal problems. So again, we have this cartilage, temporalis fascia, and we have the concho cartilage. We score this concho cartilage concentrically to prevent warping of this cartilage. Here is a Turkish delight. So what we do here is we crush the cartilages into this fine paste-like texture, and then we go for a temporalis fascia, which wraps around. We place this on the dorsal, and it gets a very, very nice, smooth effect. Can anyone tell me what this is? It's also kind of a quiz session. This is a very common graph used. What do you think this is? It's spreading something open, right? It's between the upper lateral cartilages and the upper septum. So that's spreader graft. And a spreader graft not only can increase the width of the nose, but depending on the height adjustment and the length, we can lengthen the nose and we can augment the dorsal ascent lines. Does anyone know what this is? Interactive session, you guys can chime in. This is an interpositional graft, and this is used within the middle third, augmenting the